What's up, everybody? Welcome to the Better You Project, optimizing health, hormones, and aesthetics. And today I have a very special guest. I have Dr. Betsy Yurth on the podcast episode with me today. So Dr. Yurth has been, I would say, one of the very influential educators, like female, just powerhouse when it comes to being a clinician. Really business owner. She and her husband are a dynamic duo, just as my husband and I get to work together. They also are servo users as well, which so are we. So I feel like we have a lot in common, that we got to know a little bit more about each other when we got to do a mastermind in Cabo this year. So I'm really excited to share Dr. Yurth's education, as well as the topic today is going to be all about repurposed drugs and medications, because I think if anything, recently just changes in the FDA, I think it's always good to kind of go back to like, well, what does the science actually say? And what are some things that aren't as maybe expensive, or some things that have been around and are very well researched? And you just need like a really good researcher like Dr. Yurth to explain it and just break it down for you. So, all right, let's jump in. So Dr. Yurth, background. Orthopedics. Let's talk about that. How did you get into being a longevity expert?
Yeah, I would say that that's kind of an unusual, probably an unusual way to get into longevity medicine, right? A lot of people come from ER. You came from pediatric, which is a little also a weird way to get into it, except that my best friend Cynthia Keller is pediatrician, and we sort of see that overlap between pediatrics and longevity, right? Health starts early, and so orthopedics is interesting because people always, even in our longevity field, people really don't think about joints. And so like even most of your listeners, lots of times if somebody, they're treating somebody for all their longevity issues, and then they come in with a knee problem, they send them to the orthopedic doctor. And I would argue that you guys are still the best people to be treating that. So I was doing orthopedics for many, many years, was in a busy orthopedic practice. And I started to sort of feel like all I did was kind of patch people back together, and they were never really better, and they'd fall apart a little more, and they fall apart. And so we just kind of get this cascade and decline. And then finally we'd replace their joint, and and the next joint would go. So I started to get really frustrated. So maybe now, almost 20 years ago, so I was early in this world of longevity and anti-aging medicine. So 20 years ago, and said, I need to fix people. So I started exploring how do hormones and nutrients help people to heal. And in fact, realized that hormones and all these other pieces of aging were why our joints were falling apart. This is not a wear and tear disease. It is an inflammatory disease process. So I went back, got retrained in longevity medicine, and started incorporating that into my orthopedic practice. And that didn't really go well with my partners because they didn't like spending more time talking to people and, and educating people, and realizing you could do less surgery. So I finally, after doing that for many years, and what I did is I opened another clinic, and I would see my orthopedic patients by day and then have them come over in the evening, do real medicine to them. And then finally, one of my partners said, I want you to stop ordering labs and doing this with patients. We don't do medicine here. We do orthopedics. And I said, well, I think orthopedics should include medicine, but that didn't really go over. So I finally, and really only 4 years ago, put everything into our Longevity Institute, and we do all of our regenerative orthopedic practice here now. And we'll still refer for surgery. I don't do surgery, but we refer for surgery. I do more minor procedure stuff. But if people need surgery, we'll refer them to surgery. But most people, you realize if you get them healthy, you can avoid surgery. So that's kind of how I got into this. And I really try to educate practitioners like you guys that please start looking at your orthopedic people, your knee pain and joint pain, in the same way you would look at your chest, your atherosclerosis or your brain degenerative diseases, that this is an inflammatory problem. Mm-hmm. And unless you start addressing it that way, we're never going to make a dent in this whole realm of this cascade of events to joint replacements. And that's a huge problem. So start looking a little differently at the orthopedics, just like your heart shouldn't wear out because it beats too much, or your brain shouldn't wear out because you use it too much. Your joints shouldn't wear out either. It happens because the body's not in a good state. If you get people healthier, you can actually fix their joint disease.
Yeah, absolutely. There was one lecture, I've heard you speak so many times. There was one lecture you did where you talked about osteoarthritis is diabetes of the joint. And when you said that, I'm like, shit, she's right. It was just fascinating.
Which immune inflammatory disease, just like, everything else you guys are dealing with. So don't be sending everybody off to the orthopedist as soon as they complain about knee pain. Start looking at what's going on metabolically that's creating that.
Yeah, absolutely. Absolutely. So your practice is in Boulder, Colorado, correct?
Yeah.
Okay. And it is called Boulder.
It's
Yes.
called Boulder Longevity Institute.
Right, right. I was just saying, just in case followers wanted to go follow you, that's where she's at. And so your focus now is, so you've done like all the training, you teach, you lecture, you speak, you do all the things. So mainly integrative medicine, functional medicine, lots of peptide therapy, and like kind of focusing from the inside out.
Right. And we do a lot of regenerative orthopedics. So we do a lot of joint injections, using peptides, using platelets, using exosomes. So we do a lot of regenerative orthopedics, both in joints and in spine. I do a lot of spine work because my specialty was in spine. So I do a lot of spine work with helping with disc regeneration and things like that. So we do still do a lot of just focused orthopedics, but usually it's in the realm of trying to work with people's overall health as well.
Yeah, no, it's perfect. That's perfect. All right, so let's jump into the topic at hand, which is repurposed medication. So the first one that I'd like to kind of talk about, well, first let's talk about why are we talking about this. So this was a great lecture that you did at SSRP this year. So this is in 2024 if you're listening to this later on. And why that topic?
I love repurposed drugs because these are drugs, guys, that are readily available, well tested, right? So they've already gone through all this FDA testing. Remember, for a new drug to get developed all the way from, conception of the drug to bringing it into practice is a 17-year process. And it costs really close to $1 billion to do that. So you can imagine the number of drugs that never make it because people either don't have the money or the time to invest in actually bringing that drug. It could be a very good drug. So if we take drugs that have already been through this extensive process, it's much easier for me to use them off-label. They've been deemed safe. They've been deemed effective for one purpose, but we know their mechanism of action. We can very easily transfer them to another purpose. And I'm not doing anything, that anybody can really argue with. These are FDA-approved drugs. We're just repurposing them. Just like, you guys oftentimes use drugs for off-label uses, right? Aspirin for what? So think about a drug, using it that once you understand the mechanism of the disease and the mechanism of the drug, you can now match those together and say, wait, I know a drug that works on this pathway. I'm going to pull that into play. And there's so many of them out there. And you can research, you can find more and more.
Yeah.
There's so many drugs out there that you can use for different purposes. And it's cool because now no one can come after you and take those drugs away. They're FDA approved. So I love peptides. But as you guys know, we're always fighting this battle with peptides, right? You don't have to fight a battle with these drugs. They're there and they're available. So it's kind of an interesting, way to work the system in a sense that we can do the things we love to do and yet keep everybody happy.
Right. Absolutely. Absolutely. No, it's so good. So the first one let's jump into is pentosan polysulfate. So tell us a little bit about this mechanism of action and then kind of how traditional medicine uses it, but how you use it.
So pentosan polysulfate is really it's kind of a semi-synthetic drug. It was manufactured from wood chips from a European beech tree. So I'd say it's kind of a natural compound, much like aspirin, but then synthesized. And its key way it works is it acts as a very potent anti-inflammatory and tissue regenerative mechanisms. So basically, one of its main things is that you've got nuclear factor kappa beta, which nuclear factor kappa beta is sort of the beginning of the cascade of the inflammatory processes. So once nuclear factor kappa beta gets transcribed and then and basically gets translocated from the cytoplasm to the nucleus, it tells the body start inflammatory processes. Okay, now you need that, right? But you don't need it to keep going and going and going. Right. So what pentosan can do is directly binds to the transcription factor, nuclear factor kappa beta, and then inhibits its ability to go into the nucleus, hence stopping this inflammatory cascade. Sort of at its source, right? Instead of trying to work down here with something like Advil, you're working at the source of keeping this whole process from starting. And by so doing, you stop, formation of interleukin-1 beta and interleukin-6 and tumor necrosis factor alpha. So its mechanism is very well established, and it really came out as a drug back initially the 80s, and it was approved it actually got orphan drug status for treating inflammatory cystitis. So bladder inflammation, which is a huge problem for people, right? People have this horrible bladder pain. And so it came out as a drug. It got orphan drug status initially, so it was just sort of used, occasionally. But then in the 90s, it became a full-blown drug known as drug Elmiron to treat bladder inflammation. And it works. It's a great drug for that. The problem with Elmiron is it's a pretty high dose of pentosan. And that high dose of pentosan now, we're finding 15, almost 17 years later, the drug's been around, that there are a few people, and this is still a small number, but there were a few people who were developing this eye pathology. So, and it was bad. It was this retinopathy that was a bad, irreversible retinopathy. So all these, lawsuits started going against Elmiron. Here, only in the U.S., other countries did not follow suit with this, but only in the U.S. These lawsuits started going on. Elmiron's still used, but it's got a big black box warning on it about this eye pathology. What we found was the eye pathology was dose dependent. You had to be on it for a long time at a high dose. And once you got to a very high dose over a period of time, a certain number of people, about 1% would develop this bad eye pathology. But it was enough to kind of put a little scare into the drug. And yet you have this drug that does all these great things. It's anti-inflammatory. It's anti-fibrotic. It actually is, it blocks what are called fibroblastic growth factors and pro-inflammatory gene, and also what's called heparin binding growth factor. And those are really involved in diseases like cancer. So basically, what we found is if you used it at a much lower dose but injected it instead of taking it orally, you could use a small amount of this drug to get all of its benefits, and it would take 100 years of being on this drug, more actually, to actually hit the dose that was ever associated with this eye pathology. But for those of you guys who decide to prescribe it, you're going to have people immediately Google it and go, oh my God, he's putting me on a drug that causes eye pathology. And they'll call you immediately. So I would warn my patients of this. If you Google this, this is what you're going to see. This is why it's not an issue with what we're doing. So we found is by using it at a low dose, you can get all these same anti-inflammatory reactions at a much, much, much smaller dose. So we don't have the downsides of it, and yet we have all the benefits. And so we started using it as an injection, and what we found is that it is a great drug for arthritis. It got approval first in Australia in 2019. So it got approval for osteoarthritis, and it actually now has been using it long enough that there's been a reversal of the need for joint replacements in Australia by almost 90%. I mean, that dramatic. It is that good of a drug for osteoarthritis. And some people are calling it maybe a cure for osteoarthritis. It's in phase 3 trials here in the U.S. as a drug called xylitol. So xylitol is basically low dose injected, kind of some polysulfate. And it will get approval. I don't know when, next couple of years, I'm assuming, but it will get approval. It'll probably be approved for one indication, that's knee osteoarthritis, although it's good for any type of osteoarthritis. And most recent study that came out on it showed that after a year on this drug, that there was significant improvement in joint space. So on an X-ray, not only did they halt the progression of osteoarthritis, but also actually significant improvement in cartilage space. So we know we're actually restoring cartilage. So we used to think we couldn't do that. We now know that if you block all these inflammatory properties and you increase blood flow and things like that, that you can actually regrow cartilage. It also is great just for the inflammation. So it has a great pain relieving effect for joint pain. So you're actually helping there as well. But go beyond that, when you looked at all the things it did by lowering nuclear factor kappa beta, by binding these fibroblastic growth factors, these heparin binding growth factors, that these are also very linked to cancer. So what now has been discovered, this is also an excellent cancer therapeutic. And in some cancers like prostate, cancer growth was inhibited by as much as 84%.
Wow.
Through pentosan's action as this heparin binding growth factor inhibitor. So it basically is limiting the bioavailability of these growth factors that let blood flow get to the tumor, and so it inhibits tumor progression. So 84% reduction in the progression of cancer. So I put almost all of my cancer patients on this drug. Those watchful waiting cancer patients where, your prostate cancer guys where they don't really want to do anything, they just want to wait on it, which is fine. This is a great drug for them to be on. So next, when they started looking at the mechanism, because interestingly, joint disease and heart disease are very similar. when you look at the inflammatory cytokines involved in both, you see very high levels of interleukin-1 beta in both heart disease and joint disease. So if you have arthritis, you have a tenfold likelihood of having cardiovascular risk factors. So we know that it's also a very big link, interleukin-1 beta to repurposed factor alpha, very big link to atherosclerosis and cardiac disease progression. So the thought was, well, will this work in that? Indeed, it inhibited atherosclerosis and reversed atherosclerosis significantly by as much as 50% over a year's treatment with pentosan. So you're seeing reduction in atherosclerotic plaque progression, cancer prevention. It's really good for benign prostatic hypertrophy because it relaxes the smooth muscle proliferation, so you can use it in BPH patients. And then it also has better antiviral properties than even in the mRNA viruses like COVID, very good antiviral properties. So it's one of, if you look at it and its ability to fight viruses, it's one of the great antivirals for working on things like EBV, Epstein-Barr, which we don't have a great antiviral for. This actually helps with Epstein-Barr, herpes viruses. It's very successful for COVID viruses. So people who are on this drug had much less incidence of COVID during our big COVID outbreaks. So this is also a great antiviral. So it's a little bit like, wow, here's a drug that's going to fix my arthritis, prevent atherosclerosis, help me from getting cancer. And then I'll add one more. We also know it has a really nice prebiotic effect on the gut. Now that's taken orally. It's not injected. Okay. But what we can do is a very low dose. So like New BioAge, we asked them to make us a very low dose of pentosan, like 25 milligrams, because we don't want that big high dose knowing it's linked over time to progression of eye disease. So we basically had to make us a low dose because at 25 milligrams, you could still get the prebiotic effects on the gut and it would help restore a healthy microbiome. So, so you can use a low dose orally, 25 milligrams orally for gut stuff. And then injectable is what you're going to want to use for joint and atherosclerotic plaque. I will use in somebody who will not do injections. I will do the oral with the hope that we're at least going to get some of the benefit. And I do think it's helpful. I don't have the data to support that it's, how comparable it is, but I do think I'm seeing improvement in some of these other things like the atherosclerosis in people on oral too.
That's amazing. No, all of that. Yeah. Right? I knew some of that. All of it, definitely not. But I'm just kind of thinking like, okay, how do I layer this, in cyclical fashion with some of the other peptides that I use? And I'm like, well, damn, that's a great option to kind of throw in when I'm, I'll do like thymosin beta for a little while, and then I'll do, PDA for a little while, and then add this one into the mix.
I will say that pentosan is one of those things you're going to want to use for a while. So in your patients who have injuries and arthritis, you're probably going to, I stay on pentosan all the time. I mean, personally, I have horrible knee arthritis. And I've torn my ACLs 4 times. I don't have ACLs anymore. After 4 repairs, I'm like, I'm not doing this again. So I have bad arthritis. With stage 4, if you looked at my knee x-rays, you'd say I need a joint replacement. But I have no pain as long as I stay on this drug. So I have a lot of people who just stay on this drug. I will tell you, it does take a while. So 12 weeks minimum. So it's not one of those drugs where you're going to put people on for 6 weeks and go, okay, now go off. Right? It's going to be a drug that you're going to use a little bit more for it and for kind of ongoing therapy. I use it mostly in my patients with osteoarthritis, on an ongoing basis. So if you have a patient who has osteoarthritis, who has joint pain, who has no joint disease, this is some drug you're probably going to leave them on at least for 3 months, probably longer, and maybe indefinitely.
Okay. That's awesome. That's perfect. The gut stuff is very intriguing because background in peds, like we talk about poop all the time, and I'm like, oh, it's good. Yeah. It's really good.
And, I'm a much bigger believer in prebiotics and postbiotics than I am probiotics. So I use a lot of trying to get the gut healthier as opposed to just throwing a lot of probiotics into the mix. I do a lot of, trying to get good prebiotic in and then maybe some postbiotics. And I don't think when you throw just probiotics into an unhealthy gut, you're not really solving the problem. So this is when you're working with prebiotics like pentosan, then you can actually really help restore the milieu that's necessary to maintain the good, normal, healthy anaerobes in the gut. So it's, it's a really good way to go, especially if you're doing something that's treating somebody after an antibiotic.
Out of curiosity, have you used pentosan, and then seen any kind of positive improvement in like ApoB levels or ox-LDL or small dense LDL from a cardiovascular perspective?
Well, when I run clearly scans on people, we've definitely seen improvement in the clearly. So we've actually seen reduction in soft plaque on the clearly scans. I can't say I've seen a huge drop in like the ApoBs, where it's been like this dramatic change in ApoBs, but we are seeing reduction in the inflammatory markers, so lowering of the oxidized LDL, and definitely following my patients with a clearly, because I do clearly, so it's my cardiac patients yearly, and now we've had enough data with clearly because it's been around long enough, where we've definitely seen improvement in the atherosclerosis in my patients. So a lot of my atherosclerosis patients, I'm using this on a regular basis.
Yeah.
And you will notice a lot of your atherosclerosis patients have joint problems. I mean, honestly, they do go very much hand in hand. And we used to say that, well, that's because people were more sedentary, and that's why they were developing the atherosclerosis. It's just their more sedentary lifestyles because they have joint pain. We now know that's not the case. We know there's a link between the same inflammatory processes with both of those. So it's a really nice option for those patients because you'll see a lot of them at both. Start looking at that. So you'll really see a lot of atherosclerosis, even if they don't know they have it. If you have bad osteoarthritis, get a clearly scan on mine, and you will see that they have atherosclerotic plaque. I don't have a lot of plaque, but I have some soft plaque. And so I'm nipping that in the bud, and so I'll follow. I haven't done a second clearly yet, but I'm taking this drug for a while. We'll see.
Yeah, that's exciting. We do check MPO as well, so myeloperoxidase.
Yeah, myeloperoxidase, I've seen lower as well. Yeah, we check myeloperoxidase on people too. And I think a little bit of lower glycation end products too. So on your Vibrant test where you're looking at glycation end products, you can see a little bit lowering in that. But I can't say I've seen this dramatic, where this big down in the ApoB levels, probably not dramatic.
Yeah, but MPO would be really interesting to see, to have that drop. So no, it's perfect. Okay. All right, moving on to the next one. We got low-dose naltrexone. So this one I feel like is like, it hits so many different things that I think is so unique on how you can, we use it for chronic pain and weight loss and autoimmunity, but I'd love to hear you explain this and how you use it.
Yeah, I think that this is one that probably all you guys are already using, right? But I think sometimes we don't think that much about it. It's just something we learn is, this is great. This is treats for all of our autoimmune diseases and things like that. And we don't really understand the mechanism that well and why this is such a cool repurposed drug. So, in terms of repurpose, really, when you look at how low-dose naltrexone got its start, it actually got started, I think, in like 1980. And these researchers at Penn State were studying, they were treating HIV patients. So they're actually using low-dose naltrexone, or they're using naltrexone in a reducing dose for their opioid addicts, because a lot of HIV patients obviously were from injections, and so they have a lot of opioid addictions. So what they would do is put them on naltrexone, and they would start weaning it down over time. And what they found is, very oddly, as they got to a very low dose of it, as they were weaning them off, that all of a sudden these patients had all these other positive side effects. Their moods were improved. Their pain was improved. They just felt healthier and more energetic. So he's like, wow, this is weird. It was always when they got down to that kind of lowest of the doses that they started to see this. So they started doing some research on it and found that indeed, this drug has all of these nice immune modulating benefits when you get to a lower dose. So I think the first actual study in humans was like back in 2007 by Dr. Jill Smith, who was studying it for Crohn's disease. And that's where it kind of got its start. Those of you who've been in this medicine for a long time, that this is where we used it the most, was in the Crohn's patients. It has a lot of established data in the Crohn's patients. But how does it really work? So the cool thing about naltrexone is it kind of comes in these two isomers. Remember, isomers are like a left hand and a right hand, right? So you've got this left hand, which is the dextro, and then you got the levonaltrexone. So dextro naltrexone, and they have different effects. So the dextro naltrexone binds the toll-like receptors, right? So it has this antagonistic effect on the toll-like receptors. So remember, your toll-like receptors are on the microglial cells and on other macrophages and mast cells, right? So all those bad cells that are activated in these immune responses, microglial cells, macrophages, and mast cells get activated. And so if you can block that toll-like receptor activation, you're going to downregulate the microglial activation, the macrophage, and the mast cell activation. So that's why this is such a good mast cell. In people with mast cell disorders, this is such a good drug to use, right? Or who have anxieties and things like that, where there's a lot of microglial activation. You have high glutamate.
Right.
So, and then remember, when these microglial cells are activated, they produce substance P, and and nitric oxide, and you get all these problems in this pro-inflammatory cascade that occurs. If I inhibit toll-like receptors, and that's what the dextro model does, the dextro side of it does, then I'm going to stop that pro-inflammatory cascade. And then you've got this other effect. So that's where it's working on all the immune side, right? But part of the levonaltrexone, the other isomer, the other hand of it, actually is antagonistic of the opioid receptors, right? That's why it's it was used to get people off of opioids, and why it's a little bit of a problem for us people who are on opioids, because it is going to block some of that opioid activity. But when you temporarily block opioids, when naltrexone sits on the opioid receptors temporarily, and when you temporarily block an opioid receptor, not completely, but for a short period, you actually upregulate your own opioid production, right? So body senses, oh, I need to make more opioids. And so, this is the downside of taking opioids, is you keep needing to take more and more. But if you block it shortly, our body senses they need to make more opioids. So now you upregulate these opioids, your own opioid production, and you get these really nice endorphins, which are really both make you feel good, but also favorable to the immune system. So remember, endorphins are like your natural peptides. They're produced in a lot of cells. They regulate cell growth. They help immune cells. And in fact, many autoimmune disease people have really low levels of endorphins. That's why a lot of autoimmunity is also associated with things like more anxiety and depression and pain. So by working on its opioid receptors, you get this whole other effect on this sort of central nervous system effect. It's also probably why it's so good in Crohn's disease, interestingly. That has something to do with the other side, but that opioid receptors we know are so important in the GI tract. So by using low-dose naltrexone for this brief blockade and this rebound effect, you actually can really help the gut as well. So it's such a cool drug because it has such huge, far-reaching benefits. So that's why we're pulling it in all of our autoimmune diseases. And, I think I sometimes forget this drug in all of our mast cell disorder people. All these long COVIDers with high mast cell activation syndrome, right? And you kind of forget the drug, but it has a really good effect on mast cells. So, so what are the downsides of this drug? Well, I guess the biggest downside is if you're on opioids, if you have a patient on opioids, it's going to decrease the efficacy. And if you have a patient who is going to have surgery, you have to warn them that it's possible the anesthetic is not going to work as well, or the pain meds after surgery, right? So these are the patients where, number one, if you go tell any doctor you're on naltrexone, they're going to immediately think you're an addict.
Right.
So that becomes a difficult, tricky thing. But if you don't tell them you're on this, then potentially they're going to wonder why you need so much drugs to help sedation and pain. So sometimes I will stop this drug before somebody's going to have surgery because it could make it much more difficult to get adequate anesthesia for the surgery. So that's just something to kind of keep in mind when using this drug, because it does have enough of an effect on the opioid receptors that it could have an effect there. And then, as you guys know, that one of the keys to this drug is kind of titrating it up a little more slowly. Most people respond to about a 4.5 milligram dose, but I start on 1.5. I work them up. The biggest side effect, I don't know if any of you guys have taken it. I've taken low-dose naltrexone. I still take it. But when I first started taking it, I was actually really sick. I had a really bad autoimmune disease. I was really sick. So I said, I'm fine. I'll just start with the 4.5 milligram dose. You tell people they're going to have nightmares. Okay, this was bad. I still haunted by some of the nightmares I had.
Yeah.
15 years ago. They're bad, and they're real, kind of realistic nightmares. So this kind of more vivid dreams, for some reason, the vivid dreams always seem bad. I do have a few patients who get happy vivid dreams. A lot of people get bad vivid dreams. So that's just something to kind of remind people, start slow. It also disrupts sleep a lot of people, partly because of the nightmares, and partly just because of some of the effect on the endorphins. So just kind of remind people of that. Start slow, work your way up. And, and most everybody gets to the side effects. I do, and I don't know, Lexi, if you've seen this, I do a few people, I can't get over the sleep issues. So I will dose it in the morning. Those people, the efficacy seems better at night, just because our immune systems are a little more malleable at night. But have you done that where you just dose?
I have, and in some patients, like I have a lady with POTS, and another lady with mast cell, and I actually had to start at like 0.25, and I did 0.25 for a week or 10 days. Yeah, and then
go up to 4.5.
Exactly.
Like what?
Yeah,
right? You don't need
exactly. Yeah. So, no, absolutely. To your point, especially like for patients who they really need it, but they just don't tolerate it. One of the questions I also ask patients a lot of times is I say, have you ever had a history of night terrors, like as a child or anything like that? Because then I tell them I'm a lot more cautious with them to put them on the LDN. So that's a good one.
Yeah, man, and it's probably the one drug everybody knows about and everybody uses, and it really is a good drug. I will say it's one of those drugs that you hope would be a cure to everything. Some people just don't respond at all.
Right.
Like seems like, oh, this should be great, and then they don't respond at all to it. So
yeah, agreed. I like to use it too in my Hashimoto's patients. I do feel like it has such a great impact on.
I think it's great for lowering
TPO antibodies. Yeah, for sure.
Yeah. I think that's a great use for it too, because we always forget those people. This is same immune disorder, right?
Yeah.
So LDN is a great way to lower those antibodies, because that can be really difficult. Stopping
for sure.
Taking contrast to be your best bets.
Yeah, lorazepam and LDN. That's like the combo that a lot of times I'll use for those Hashis patients to try to help get their gut healed up.
Yeah, and you have to always remember with all these immune patients, right? I mean, you brought up lorazepam. For all these immune patients, that lorazepam should be everybody, because if you've got an immune disorder, you have a gut problem. And so, if you have patients who have autoimmune disease, I think almost all of them deserve a gut workup and probably to be on lorazepam. It is such a great drug as long as they can afford it. But it is such a great drug. And you talk about drugs that could never make it to market. This is a goldmine drug. It's a goldmine drug. For celiac patients and to repair tight junctions. There's nothing else that does this. And yet the company that made it could not get enough money, or they could not meet the FDA requirements to have enough people to actually ever bring this drug to market. So it's just sat on a shelf.
Yeah.
I mean, it's
crazy. It's crazy.
Not being used, even though it's so advantageous to so many people. So you talk about this process that the FDA sometimes becomes inhibitory. I mean, I love the FDA for some of the things they do, but to make it inhibitory for some of these drugs to get to market, a small company doesn't have $1 billion,
right?
And they couldn't. In this case, they couldn't even find enough patients to qualify who had celiac disease to qualify to get the FDA's approval. So so it's good for us because we pulled it into our material, but but it's too bad. Really, it's been sitting on a shelf for many years doing nothing.
Right. No, for sure. Okay, so the next one we're going to talk about is amlexinox. So if we could talk a little bit about the mechanism of action and then kind of the impact on inflammation as well as weight loss.
This is actually maybe one of my favorite drugs. So for you guys, if LDN's not working, think amlexinox. And a lot of times I'll combine the two of them. I'll use both. I take both. But this is a really cool drug. So as a repurposed drug, it got its start as a drug called Apsol. And Apsol was designed as a gel or a paste that was for canker sores. So it's just a paste, and Lexinox paste that was put on canker sores. Mm-hmm. And it worked very well, but it ran into the problem that it burned a lot when people put it on. So nobody really liked it. And it did not, at least here in the US, have enough of a market. So they couldn't sell it. And so now you'll look, so when you guys don't get scared by this drug, because if you look it up, it'll say, oh, the drug was pulled from the US market. It was pulled from the US market because it didn't have enough. The drug company self-pulled it because they weren't making any money. They could not sell enough of it to make money. So don't get split off by that. It was pulled by the US market. If there was nothing wrong with the drug, it was the company self-pulled it because of that. In other countries like Japan, it is widely used. It's one of the go-to drugs for asthma, allergic rhinitis, conjunctivitis, any of these kind of inflammatory, allergic type diseases. So it's a really good anti-allergenic drug. So it's a great drug if you guys have, people with seasonal allergies, horrible seasonal allergies, or triggered asthma by things. Mm-hmm. Great drug for these people. So it has really good anti-allergenic and anti-inflammatory properties. It's another great mast cell stabilizer, right? So it's probably one of its, I think, best uses is for these atopic conditions like asthma and hay fever. But really, it's so good at balancing the immune system and helping in all these inflammatory diseases. So it's going to act as a mast cell stabilizer. So it reduces the release of histamine, leukotrienes from the mast cells and neutrophils and monocytes. For cancer, it's going to inhibit what's called Th17 cells, not these Th1 cells, which is what you want. You want to inhibit you don't want to just inhibit these T helper cells. You want to inhibit T helper 17 and not Th1. So it knows to do that. So it's a very, very good cancer cell. Here's another drug for your watchful waiting people with things like prostate cancer, because it really showed that it will inhibit the progression and metastasis of cancer. It also actually is, it promotes cellular autophagy. So it actually is an mTOR stimulator. So, an mTOR inhibitor. So it's going to induce apoptosis. It's going to help cellular autophagy. But you brought up its other cool effects. So I probably use it more in my practice for autoimmune disease, but where it will actually come back to market and where it's being looked at the most now, because weight loss still somehow is more important than everything else in the world, that is for metabolic diseases and weight. So what it does from that purpose is that it stimulates lipolysis. So by upregulating AMPK, you're going to reduce insulin resistance. You're going to stimulate mitochondria. You're going to lower cholesterol. And we know that a lot of obesity is inflammatory driven, particularly this Th17-driven inflammation. That's what causes that visceral fat is Th17. So basically, you can inhibit Th17. You have a great way to reduce visceral fat. And visceral fat is that hard fat to get rid of, right? You look at the dad bod guys, they might not be all that fat, but they've got these big bellies. And that's because that fat becomes really resistant to lipolysis. And yet it's a very dangerous kind of fat. And this is a really good drug for helping there. So if you have these guys who have, they're not really fat, but they've got those big bellies, that visceral fat, they just like this. This is a really good drug to think about. So when you lower this Th17 inflammation, you actually sensitize these fat cells to lipolysis. And you start fatty acid oxidation and reduction of fat volume. So it works in a very cool mechanism. But also really on cholesterol as well. So it's really good lower cholesterol agent. And this will lower ApoB. So this definitely will lower oxidized LDLs, but this will lower ApoB. So Methonox, again, I use it a lot more in my practice from the autoimmune perspective, but it's a nice add-on, particularly if you're using your GLPs and people aren't responding to them. Think about Methonox, because it may be that you still have too much of this Th17 inflammation. Remember, with your people, not everybody responds the way they should. So you have to think what other pathways am I not striking? So it's one of the places where GLP agonists are not striking. So I can actually hit with this either in combination and now accentuate the fat loss, or even switch over to this, because cost-wise, it gets expensive to do all of them, right? There's a great article that came out a while ago. I can't remember the year, by this guy, John Loudon. And he did this article out of Journal of Bioanalysis and Biomedicine. It was called Repurposing Methonox as a Red Light Cure for Everything. And that's because it really showed to help neurodegeneration, coronary artery disease, arthritis, obesity. So much like our pentosan, here's another really cool drug. This drug having really, honestly, zero downsides. The biggest downside of this drug is in my autoimmune patients is weight loss, because sometimes you don't want the weight loss, right? And it's so good for their immune system, and yet they can't keep weight on. So that's probably the biggest side effect of this drug, which in a lot of people you like, but in some people that becomes a problem. And I've had to pull some of my people, like rheumatoid arthritis patients who are doing great on this drug, and they pull them off because they just get too skinny. I can't get weight back on.
Gotcha.
So, but otherwise, from a side effect profile, you do not see side effects in this drug. You don't get nausea. You do not see side effects in this drug. It is a really cool drug. And I will say it is probably one of my favorite drugs.
Yeah, no, it's great. And I love it too, in that it's not an injectable. So some patients who get needle fatigue.
Exactly. Yeah, everything we do is so hard for people.
Yeah.
They got 6 injections to do. So this is nice. Ideally dosed 3 times a day, but I lots of times, because it's so hard for people to do a 3 time a day dosing, we'll dose like 1 in the morning, 2 in the evening. So trying to get 3 in there. But you can sometimes get by with a little less too. So you can sometimes titrate down off this drug too. But another really good, again, guys, if you've got people who have that more atopic dermatitis kind of stuff, they have allergies, think about that patient. And they've got a little visceral fat, and they've got that kind of always kind of red eyes and stuffy noses. this is a great drug to think about for them because they actually probably have high Th17 levels. They're going to be at increased risk for certain cancers. So this is a really good drug to think about for those, right?
Yeah.
I've not used this drug. I use LDN more in when we're talking about the Hashimoto's. I've not used this drug as much in Hashimoto's. I suspect it would be efficacious too. But,
Sure.
but cost-wise, LDN is much cheaper.
Oh, yeah.
Much less
Yeah,
expensive.
for sure. For sure. All right. Next one is telmisartan. So this one was one that I heard in your lecture, and it's not one that I've used often. And so I think this was a good one to talk about.
I will tell you, I think this is a really underappreciated longevity drug. Okay. And it sounds a little weird, but if you guys start looking into it, you'll sort of see why. Telmisartan, most of us know it for blood pressure.
Mm-hmm.
It's an angiotensin receptor blocker. And so it's a really good drug for blood pressure. So it's my go-to drug for blood pressure. It's not as widely used out in the, it's sort of gotten abandoned over time, but it's a really nice drug for blood pressure. However, it has all these other benefits. So it's this kind of fascinating drug because it started for hypertension. When you look at its metabolic effects, it activates what's called PPAR gamma. So a lot of you guys know this peroxisome proliferator activator receptor gamma is really kind of important. And when you activate that, you're going to improve insulin sensitivity, glucose metabolism, help reduce visceral fat, and really help mitochondrial function. So that's one of its big pluses, is this PPAR gamma stimulation helps healthy mitochondrial function. It's why this drug is actually a banned WADA substance. So like your kids, you use it when they go wrong because this is a banned WADA substance.
Right.
Because it does that much, in fact, enhance performance. This was the drug, guys, when that little skater, the Russian skater who got pushed out, this was the drug she got caught with. As she said, you said, oh, with my grandpa's or something. But it wasn't. I'm sure they were doping her with this because it's a great drug to dope with. So it is that good of a metabolic enhancer and improving mitochondrial function that you will actually see improvements in endurance. So PPAR gamma agonists are really good for your athletes because they will improve endurance activities and even more short-term activities because that mitochondrial activity depending on how you time dosing. But they also, when you stimulate PPAR gamma and when you block angiotensin receptors, you also have a lot of cardiovascular protection. So you're going to reduce arterial stiffness, improve endothelial functions. It's a great go-to in those high myeloperoxidase people, right? Because they're endothelial, they have poor endothelial function. It does cross the blood-brain barrier. Most angiotensin receptor blockers do not. This one does. The others do a little bit, but this one does a lot. Okay. It appears to have significant neuroprotective properties as well. It's been shown to improve because of the preservation of PPAR and also the blocking of angiotensin receptors, that we actually not only improve exercise capacity, but we seem to be able to maintain muscle mass better as well. And then we always have to look at kind of these things that are working epigenetically, right? That they're actually changing our own body. This does that. It actually has gene modifying effects. So it regulates some of the genes in lipid metabolism to the point where when you stop the drug, you'll still see improvements in lipid metabolism. And then we also know, we know when you activate AMPK, we all know that's kind of one of our goals in longevity is to activate AMPK or cycle your activate AMPK and mTOR. So that when you activate AMPK, you're going to help regulate some longevity genes as well. It also seems to have some nuclear fracture kappa beta, which talked about that before with pentosan. It also seems to have some modulatory effects on a genetic level. Same thing, keeping nuclear fracture kappa beta from being activated. So the big thing here is, when you look at doses for, typically for hypertension, we're using like 80 milligrams of this drug. And obviously, if you don't have hypertension, like I have low blood pressure, so if I took 80 milligrams, I feel dizzy and not good. So you can back it down, do 20, do 40 milligrams, right? Ideally, if you could get up around 40, that probably is the best benefits. But if you have people who still have blood pressure effects on that, go down to 20. But I think this is a really cool drug because it's cheap, it's widely available. Your insurance will pay for it even, right? And yet it has all these longevity properties, neurodegenerative prevention properties, metabolic enhancing properties, energy producing properties. So it's another drug I take this is a great drug too. If you have somebody that's going to be coming I live at high altitude, right? So you're going to be coming to high altitude. This is a really nice, if you use a PPAR gamma agonist, you're going to be able to tolerate altitude much better. You can especially start like a week before. So I think this is a drug you guys should really look at a little bit more and think about. Obviously when patients docs see they're on telmisartan, they're going to go, why are you on this? If you don't have high blood pressure, that's what they need to understand.
Yeah.
So you have to kind of explain that to them. Yes, this is a blood pressure medicine. We're not using it for that. We use it at a lower dose, blah, blah, blah. But also you have a lot of people who are hypertensive, right? So
Yeah. Oh, for sure.
Out their blood
For
pressure
sure.
medicine for this.
So I'm thinking in our panel of blood work that we draw, we check in like what we call our longevity panel, the ApoE is on there. Patients with ApoE4, I think this
Nice option for ApoE4 people.
Yeah.
Right.
Like
So
this
great
would be,
option.
I think, a good.
Along with your plasmalogens, right? This is a good option because it does cross the blood-brain barrier effectively.
Yeah.
Nice, cheap, easy thing that you could do. And remember, the ApoE4 gene, the biggest problem is lipid metabolism in the brain. And so this is going to help that lipid metabolism in the brain.
Yeah.
Well,
Well, this is great.
a lot of plasmalogens and telmisartan. We know with enough plasmalogens, the ApoE4 people probably you can kind of normalize them. So there, it's interesting. Like there's no gene there's nothing in our body that's all bad or all good, right?
Right.
Like Lp(a), we sort of think, it's a horrible thing, and it is because your cardiovascular risk is so increased. But Lp(a) people are also much less likely to die in bacterial infections. So if there's a zombie apocalypse, they're going to do better than the rest of us. So there's benefits to everything. ApoE4 too. There's some benefits to having an ApoE4 gene, but not so much for dementia, right? So if we prevent the bad things that are happening, which is controlling the poor lipid metabolism in the brain, using plasmalogens and things like telmisartan, I think you're going to see that people are going to live normal lives.
Yeah. Yeah. Oh, for sure. That's a good one. I'm just going to put that in my notes and pocket that away for my next longevity panel. Next one. I love this one because we use a lot of it in practice. Tadalafil.
Yeah. So I will tell you, almost all my patients are on tadalafil, Cialis, men and women.
Oh yeah, yeah.
And so when my women, your patients will always forget. They're like, I don't remember why I was on this drug. So their doctor, why are you taking that drug?
Yeah.
No, I don't remember. So you're gonna have to keep reminding them because everybody sort of freaks out when you're a woman taking tadalafil. But when you look at the PDE5 inhibitors, the phosphodiesterase 5 inhibitors, they are really, and you guys are going to watch. These are going to be compounds that are going to become much, much more researched for supporting longevity. And when you look, because when you inhibit some of the phosphodiesterase, but 5 is one of the biggies, you actually have huge benefits. You improve cardiovascular aging, improve endothelial function, reduce arterial stiffness. So again, high mild oxidase, go on tadalafil. High oxidase LDL, go on tadalafil. This is that oxidative stress. This is really good to improve nitric oxide function in the vessels. Probably has some good effects on helping with cardiac fibrosis. So on your patients who, ended up with myocarditis, post-our COVID episodes, this is a great drug to have them on. It has a lot of metabolic effects too. It activates brown fat, improves insulin sensitivity. They found a huge neuroprotective benefit. So they found the guys who were taking, so they stumbled on this because they found the guys who were taking Cialis on a regular basis for libido and erection quality had much less dementia. And that's because you're increasing blood flow, which is great. You're also reducing neuroinflammation. And it also has a very unique effect to help support the blood-brain barrier, so less toxins get to the brain. So you're able to clear stuff out of your brain and keep bad stuff from getting to your brain. Again, another WADA banned drug for a reason. It improves exercise. It enhances muscle perfusion. It enhances oxygen delivery to the muscles so you can pump more weights, right? Lift harder, get a big muscle pump. Enhances nitric oxide availability. It probably has some effect on sirtuins. It looks like it has some effect on sirtuins and some of the longevity pathways, so it has other effects. So these PDE5 inhibitors are really, and again, low dose, using like 5 milligrams, sometimes 2.5, people have blood pressure issues. So these are kind of a great little, again, super cheap add-on for people to just do on a regular basis as they get older, especially in your people who are obviously showing endothelial dysfunction, which, post-COVID, we're seeing so much of this, right?
Yeah.
There's so much damage to, spike protein does so much damage to the endothelial wall. And so this is a nice go-to. So think about, combining like tadalafil and telmisartan and look at your effects there. Again, you won't cause WADA. So if you're a tested athlete, don't do this. But for those of us who are just recreational athletes, here's a great option. So if you're going to be going out and doing your sport, it's great to do the tadalafil right, 30 minutes before you go out and lift your weights, because you're going to get a muscle pump. It's a great pre-workout, honestly.
Yeah, no, that's awesome. One thing I was going to say so I live in Indiana and we're just cold already here. It's like 20 degrees. My ladies with Raynaud's, this has been great. This has been really, really good. I have a patient who's a teacher and she does bus drop off duty. So she's out there in the cold and I started her at 2.5 and then I increased her dose to 5. And it's actually seemed to work very well for her.
Yeah, there's some good down on PD5 inhibitors in Raynaud's. Yeah, I have pretty bad Raynaud's, and it helps me a lot too. Also using nifedipine topical. I don't know if you've done that, but that
no,
great.
I was just reading that the other day.
Yeah, topical nifedipine. Like I always use that before I'm going to go out in the cold.
No, that's fascinating. That's good.
So use that combination. But yeah, and it makes sense, right? We're reducing the endothelial dysfunction because we look at Raynaud's, it's just endothelial just clamping down, and so we're reducing that. We're increasing blood flow to the extremities. It's doing the same thing in the brain, right? Same thing's happening in the brain.
Yeah, absolutely. Next one is going to be aspirin. Let's talk a little bit about this drug that has been around forever.
Drug, right? We've had a lot of controversies through the years. When you look, aspirin's like, oh, aspirin's good, aspirin's bad. But I think you need aspirin. And I'll tell you why. And a low dose, you don't need a lot, 81 milligrams. But the big thing is we have these pathways. They're called aspirin-mediated pro-resolving pathways.
Yeah.
So basically, with these pro-resolving mediators, so when you take your fish oils, right, your omegas, what happens is those omegas become things like resolvins and lipoxins and defensins. And those are actually one of the reasons that the omegas are so valuable. But you actually need aspirin to help some of those pathways. So like particularly something called lipoxin A4, which is actually really important for an anti-cancer agent. That needs aspirin. So your omegas can't really go to, they must be able to do somewhat, but not very well without aspirin on board. So basically, and this is kind of through this generation of acetylated COX-2, and when you take those, that's what stimulates these aspirin trigger pathways. So you get much more resolvins, so now when you're taking your omega-3s, along with a low-dose aspirin, you're going to see a lot more anti-inflammatory benefits from your omega-3s because you're going to be making more of these resolvins and defensins, okay? So you're going to actively, remember those, so again, like all inflammation, not, inflammation is good and bad. We need some inflammation, but then it needs to turn off. So we always say, oh, omegas are a great anti-inflammatory. Well, they are, but one of the reasons they are is because of their conversion to resolvins, and resolvins are what stop that inflammatory process. So when you have people who are sick, long COVIDers, or people who have had surgery and their joint just stays swollen after the surgery, put them on low-dose aspirin along with the omega-3 fatty acids at a high dose, and you're going to see these resolvins come into play. What do resolvins do? Exactly what they sound like. Resolvins resolve. They stop that inflammatory process. So that allows you now to start this regenerative process. And that's where now you pull in your BPC, your thymus and beta-4, and these reparative things. But if I'm going to keep fighting inflammation, and I'm trying to throw in these repair mechanisms, I'm not going to do a very good job, right? I need to be treating inflammation too. Aspirin's interesting, is one of those circadian drugs. You need to take it at night. So aspirin does not have the same benefits. Take it in the day and night. And you don't need a lot. You need 81 milligrams. Safety profile 81 milligrams is very low dose. But do remember that nighttime dosing. We seem to do a lot better making these pro-resolving mediators taking it at night than we do in the day.
Fascinating. No, I did not realize that it was a nighttime thing. The other thing that I use aspirin for a lot is my LP(a). Like I know you can use niacin, but I tend to use aspirin. But like now, all the more reason why we need it.
Yeah, so that kind of makes sense too, because you're going to reduce some of that endothelial inflammatory process the LP(a) is creating. So I think you secondarily helping there, and so I haven't really used it in that effect, but I put almost everybody on it. But that's interesting. It'd be interesting to watch that.
Yeah, for sure. Okay, we got 2 left. I know you're busy. Okay, methylene blue I will just kind of skim over this one, and then we're going to end on metformin.
Okay.
Okay.
So methylene blue, and a lot of you guys have heard about methylene blue, right? And when you think back on what methylene blue got its start for, is what was its original use? It was an anti-malarial drug, right?
Mm-hmm.
So it had two purposes: for malaria and for treating methemoglobinemia, right? Those were its two purposes, and that's all it was used for. But we now know one of the reasons it treated methemoglobinemia, and maybe some of its malarial effects too, has to do with its kind of core mechanism. And what's very cool about this drug is it acts as sort of an electron shuttle. So it accepts electrons from NADH and then it transfers them directly to cytochrome C. So basically, when you look at the electron transport chain, right, you're going through these four complexes. It kind of bypasses complex 1 and complex 3. So it's almost like I can do, if I have a, I'm trying to pass a baton from one person to the next. If I skip two people and throw it over, I'm going to pass that baton a lot faster. So you can much more efficiently get ATP by just shuttling faster, by skipping these two transports. It also is going to reduce some of this electron leakage that occurs by bypassing these two things. So you're going to get less reactive oxygen species. So even when there's mitochondrial damage and the electron transport chain isn't working very well because the cytochromes have been damaged, then you can still work with methylene blue to enhance ATP production. So it's great for anybody who has mitochondrial stress because I can make it more rapidly. And most of us have mitochondrial stress. Not everybody, but a lot of people, right? Mitochondrial stress. Most of us, as we age, do. And definitely if you're, you're athletes and people like that, or your people, your long COVIDers, right? They have mitochondrial damage. So when you increase ATP, what are you doing? Well, not only can I perform better, I have more neuroprotective effects because my brain is the biggest energy need there is. My heart and my brain. Heart, brain, muscles. Those need ATP more than anybody else. But primarily the brain is a big energy suck. So when you look, one of the things we do in our practices, we look at what's called a WAVI scan, and we can see the brain energy, right? And people who are developing dementia, you see the energy of the brain drop. So they're just not making as much ATP. They have less brain energy. So methylene blue is really nice for neurodegenerative people because it's going to help make ATP faster and in more abundant supply so they can keep up. So the other interesting thing about it is it inhibits monoamine oxidase, so MAO. Remember what does MAO do? It's breaking down neurotransmitters like serotonin and dopamine and norepinephrine. All of us start losing MAO as we age, right? So what is a natural way to improve MAO or to basically block MAO? Methylene blue. So methylene blue inhibits MAO, and then so you can maintain higher neurotransmitter levels. So they have better serotonin, better dopamine. So think about this people, your people when you look on your Dutch test and they have low dopamine and they have low norepinephrine, epinephrine. Put them on methylene blue and you'll see those numbers come up very nicely and in a more homeostatic fashion. You're not going to overshoot, right? And I will say it's one of the reasons you have to be careful if somebody's on a serotonin uptake inhibitor. And it's rare, but you could potentially push them over the edge with serotonin with methylene blue. So be a little careful of those people because it can increase serotonin levels. I've never seen it happen. I think it's probably one of the overblown things we hear about, but doesn't happen. But it's something to keep in mind, right? But that's one of the cool things about it. That's why methylene blue, we don't think about it for depression and anxiety. It can be cool. Like you could use the little troches for rapidly, if you get an anxiety attack, you can get a really rapid, absorption just by putting blue, putting it, in your cheek and just sucking on it. Otherwise, you get oral. You don't have to have the blue mouth that everybody has on their Instagram feeds, but you can orally to avoid having the blue mouth. So I think it's a great drug to think about in your new neurodegenerative people. All of your mitochondrial dysfunction people, that's going to include your long COVID, your chronic fatigue people. This is a drug you're going to want to pull out. And dosing is, a lot of times you can get away with very low dosing. You can go up higher. I'm using, 0.5 to 2 milligrams per kilogram. People, I'm using low doses, but you can go up pretty high in some of your people who have more neurodegenerative stuff. I think the only concern is should you be testing glucose 6-phosphate deficiency, because people who have G6P, glucose 6-phosphate dehydrogenase deficiencies, which is about 400 million people, so it's not that small. Cause hemolysis, not at lower doses, but if you're going to run IV methylene blue, I don't do IV methylene blue. If you're going to consider IV methylene blue, you should run a G6PD on people to make sure that you don't need hemolysis. Because even in relatively small doses, that can be dangerous. So, should you test a G6PD on people, probably you're going to put them on any kind of more significant dose of nephrin blue.
Yeah, agreed. Completely agreed. No, it's been such a great add-on to some of the things that we do. We also use it as like an antibacterial, an antiviral.
Yeah, that would be great for bladder, right?
Yes.
So it's a great anti-associated. If women have chronic bladder infections, this is a really nice option too.
Yes. Yeah. I had a urologist who was super pumped that I had put the patient on it because she has chronic UTIs, and she was very excited to see kind of how she would progress as far as a reduction in her UTI. So good stuff. All right. The last one, I feel like gets so much hype, but I'm so excited to hear you talk about why we need to maybe reconsider this. So the last one from our longevity repurposed drum roll is going to be metformin. So what it is and why does it get so much hype, but why we should rethink that.
Yeah. And Lexi and I have talked about this because we're both sort of the same mind that metformin has some really good benefits. So here it is a great drug for treating diabetics, right? Mm-hmm. And when you get better metabolic control, you enhance longevity. But also metformin is an mTOR inhibitor. When we inhibit mTOR, like rapamycin, we also help with longevity. So inhibit mTOR, get higher AMPK, help with longevity. The problem is that when you inhibit mTOR, you also have another problem. Is that we need mTOR for muscle building. And so it's at the expense of muscle. So yes, do I think this is a good longevity drug? Yes. But the downside being it's expensive something that to me, it's really important. And that's muscle. I do not want to be a frail little old person. I want good muscle mass. And we know
you won't be.
So right. And so when we look, you saw, particularly as people got older, that people on metformin had a much harder time building muscle and much higher sarcopenia. So people are using this drug for longevity, and yet this expensive build being able to build muscle, and muscle is clearly going to be protective to our bones, protective to our brains. Muscle is still the currency of life. And so, I think there's better ways now of reaching the same endpoint. So we have to control metabolism. We have our GLP-1 agonists. Low dose GLP-1s are probably much better longevity drugs than metformin. Or the sodium glucose transport inhibitors like the SGLTs like Jardiance is, also much better, working on some of the similar mechanisms without the downsides. So the only reason to use metformin in my mind right now is in somebody who is metabolically unstable and cannot afford the other things because it is cheap. But even in those people, I tell them we're going to have to cycle this or you're going to lose muscle, right? And I'm going to work very hard to do things to maintain muscle on this off cycle. So, we're suppressing mTOR, but at least we're allowing it to come back, suppressing it allowing it to come back, and working on other ways of metabolic control. But otherwise, guys, there is just much better longevity agents out there now. The GLP-1s, the SGLT inhibitors, these are much better drugs because they're not at the expense of muscle mass.
See, you heard it from the expert. It's not all it's crapped up to be. So there it is.
Yeah. We have this argument. We're this big longevity docs group, and this argument goes on. I mean, there are people who still love metformin. I personally think you got to look beyond it.
Yeah.
Move on.
Yeah. So of that whole list, Betsy, what is your favorite longevity drug?
So that's a tough question because I think from my personal perspective of helping, with so many immune issues and things like that, I love Amlexnox. But from a longevity perspective, honestly, I think telmisartan may have the most significant potential for health span enhancement. And, it's because it's working on these kind of multiple core aging pathways. It uniquely affects PPAR gamma and AMPK pathways. It supports mitochondrial function, supports autophagy, is anti-inflammatory, has cardiovascular benefits, it's muscle building benefits, improves insulin sensitivity. It's cheap. It's easy to take with a low side effect profile. So honestly, when you look at these other drugs like metformin or rapamycin and their downsides, rapamycin, they may be something compromised, metformin with its muscle loss. Here's a drug that's doing a lot of the same things, except without any of those downsides. And, I think there's other great drugs, for this as well. But if I'm going to look at something that would be universally able to be used by everybody because it's so accessible, it's almost going to be high on that list.
That's great. No, that's perfect. I've got all kinds of notes that I'm ready to like start doing, tomorrow. So it's good. That's good. Well, thank you so much, Betsy. I know you're super busy educating, speaking. I'm probably going to see you in a couple days at A4M in Vegas. I'll be there. So that'll be exciting. Where can people find you or your practice if they're interested in working with you or learning more about your practice?
Sure. So if you guys just go to boulderlongevity.com, that's our institute, which is here in Boulder. We see patients all around the world, so licensed in most states. And so we see people virtually all over the world. So follow me at Dr. Yurth on Instagram or at Boulder Longevity for our clinic. And then we have this Human Optimization Academy, which people love. If you go to BLI.academy and sign up for that, we do a lot of educational courses on that, teaching you how to read your own labs, things like that. But also we have these Q&As. So there's a lot of providers. There's both just people who are not medical providers, but a lot of providers on there who come largely for some of the Q&As, because the Q&As are bar none amazing. The people ask, these people are, they're all pretty good functional medicine providers, and they ask some really astounding questions. So we get these great discussions once a month. It's worth it just for the Q&As. So join BLI.academy, come to those Q&As. They're fun. I mean, they challenge me because the questions are so tough. The things people ask, and we cover everything. So yeah, I think if you guys want to learn more at the Institute, go to longevity.com, follow me at Dr. Yurth. I'm not a great I'm not nearly as good as Lexi at social media, but I try and get in there now and then. And then join our academy, BLI.academy.
Yeah. Yeah, no, that's great. I will tag all those things in the socials, and I'll tag you, Betsy. So all you have to do is just hit accept, and then
add a story.
Yeah,
I can do that.
Yeah, that's what Leonard's like. I don't have to do it. Lexi's already tagged me, so that's good. It's good. Well, thank you so much. I so appreciate you, and
I appreciate you too.